Now, talking about arrhythmias, arrhythmias can be divided into 8 according to the electrocardiogram. Arrhythmias can be supraventricular excess systoles, paroxysmal atrial tachycardia, atrial fibrillation, atrial flutter, nodal excess systole, ventricular excess systole, ventricular tachycardia, and ventricular fibrillation. Normal sinus rhythm is characterized by P wave, constant P wave configuration, normal PR interval, constant PP, RR cycles, and the rate would be 60 to 100 per minute. The arrhythmias of sinus origin may be sinus bradycardia, sinus tachycardia, sinus arrhythmias, wandering pacemaker in the sinus node, sinus block, and sinus arrest. We have already discussed sinus block and arrest in the atrioventricular blocks. Sinus bradycardia is said to occur when the heart rate is less than 60 per minute. Sinus tachycardia when the heart rate is more than 100. Sinus arrhythmias characterized by P wave of sinus origin, normal PR interval, normal P wave configuration. The rate is less than 100, irregular PP and RR interval. This is sinus arrhythmia. The irregular PP and RR intervals are seen at heart rate is less than 100 here. The P wave configuration is variable because of accompanying bonding pacemaker. This is accompanied by bonding pacemaker. Sinus arrhythmia with bonding pacemaker. Premature atrial contraction. An atrial premature beat results from premature atrial stimulation from ectopic site. The ectopic P wave appears earlier than the expected P wave. Ectopic P wave differ in configuration, may be upright, isoelectric, or inverted. The compensatory pause is not complete. Atrial tachycardia, usually the rate is more than 100, but in paroxysmal atrial tachycardia, the rate is usually from 160 to 250, and it is all are conducted to the ventricles. That is 1-to-1 conduction. In paroxysmal atrial tachycardia, the rate is 160 to 250. Now here, the atrial tachycardia is converted to sinus tachycardia. This is atrial tachycardia, sinus tachycardia. It may have happened spontaneously by conversion or by medical conversion. When the atrial ectopic rate is more than 250 to 350, this is known as atrial flutter, and the P waves are very typical and known as F waves. F waves, and since the rate is very high, 250, 350, all atrial rates are estimations are not conducted to the ventricles. So usually variable blocks are seen. Now here we can see 3-to-1 block, here 2-to-1, and here there is variable block. This is atrial flutter with block. Atrial fibrillation is still more rapid atrial rate, more than 350 per minute, and the F waves or fibrillatory waves are recorded on the baseline just like small undulations with variable blocks. Here, atrial fibrillation with WPW syndrome because the QRS complex is typical of WPW and variable RR shows atrial fibrillation. Here, it is atrial fibrillation with rapid ventricular rate. Rapid ventricular rate. Junctional ectopic beat. This is from atrioventricular node. It is just like supraventricular ectopic except that the P wave is inverted. P wave is inverted. Ventricular ectopic beat. The ventricular ectopic is characterized by it is premature in time, the compensating pass is complete, no P wave, and the QRS complex is wide. Moreover, now here two ventricular every normal QRS complex is followed by one ventricular ectopic. Every normal QRS. This is known as pulses by Gemini. Here two normal cardiac cycles are followed by one ventricular ectopic. This is known as trigemini, ventricular trigemini. And here three normal cycles are followed by one. This is known as quadrigemini. Ventricular tachycardia, wide S complex, QRS complexes, what nearly at regular intervals. This is ventricular tachycardia. Here above it is idioventricular, which is the impulse comes directly from the muscles. The rate is slow. Ventricular regular complexes, wide ventricular tachycardia, become totally irregular ventricular fibrillation. This will be followed by a straight line showing no electrical activity, means death. Thanks for watching.